Clinical integration is really having an entire community, which includes hospitals and doctors and home health and SNFs and acute, post-acute care facilities, coming together to give seamless care so that you actually have no bad handoffs of care, so that you give the right care at the right time at the right place. So it's really about activating the entire community. And as we go forward with different changes in the way we're being paid as physicians and as hospitals, care is going to migrate out of the hospital into the community. So you're going to have more and more care being done outside of the hospital. So it's really a time of great change, and clinical integration is really just all the different providers and hospitals and facilities working together to improve the population health of the people that live in the Reading community. Clinical integration is really, really important for all healthcare systems in the United States because basically they've changed the rules on us. With the Affordable Care Act, which was passed 6 years ago in March, clinical delivery systems are now going to have to deliver care that is less costly and has higher quality. And so basically, under the pilot programs in the Affordable Care Act, we're going to be holding hospitals and doctors and other providers accountable for decreasing the per capita cost of healthcare and increasing the quality of the healthcare that we deliver. Now, when you have both independent physicians in a community like we have in Reading, and also physicians that are employed by the health system, you have to be worried about the Department of Justice and anti-fair trade. So there are certain ways that there's a safe harbor that doctors can work together to improve the quality and cost of care if they're really doing it to improve the community health outcomes. So somebody once said that you can summarize the Affordable Care Act in 4 words: no outcome, no income. One way to move toward clinical integration in a community is to have a clinically integrated network. And so basically you have a structure with a governance structure where you can have independent physicians and hospital employed physicians working together in a way that is legal to improve the population health of the community. There's a lot of different pilot programs going on. You've probably heard about accountable care organizations. You've probably heard about pay for performance. But there's actually a new one called MACRA, which is changing the way that we pay doctors. And the short explanation for MACRA is, the good thing about it is it got rid of the SGR fix, which is that every year since 1998, there was a possible 20 to 30% decrease in funding for physicians. And every year Congress then, at the last minute, got rid of that SGR problem. The bad thing is, if you're a physician, is they're now going to create a MIPS score from 0 to 100 that's based on IT, it's based on how much quality you're hitting quality metrics and a bunch of other things. And they're going to actually score individual physicians from 0 to 100. And that's going to be interesting because that will be apparent to the general public. So what they're basically doing is saying, we as payers, both private and CMS, are going to hold individual doctors, individual hospitals accountable for both cost and quality. And that level of transparency has never been done before. And it's going to be interesting to see if patients will want to go to a provider that has a MIPS score of 22 out of 100. Probably not. So there's one way that systems can get out of using the MIPS score, which is totally transparent, and that's called alternative payment models. And those are things like pay for performance, bundled payments, and accountable care organizations. If you're getting most of your payments through those alternative payment models, then you can avoid having the transparent MIPS score. I tend to try to think about clinical integration in 4 buckets, or 4 silos, if you will. One is, how do you create a governance structure that's fair to independent physicians and to employed physicians, that's fair to both the hospital and also fair to the doctors? So that's a really important thing that you have to work on. The second bucket would be aligning incentives. If you think about fee-for-service, the incentives really are not very well aligned with decreasing per capita costs and increasing quality. So with fee-for-service, the more you do, the more money you make, whether it's necessary care or wasteful care. So you want to align incentives toward decreasing per capita costs and increasing quality. The third bucket is really clinical programs or population health. So can you, in Reading, identify some populations that you could take better care of? And in some places what they do is they look at really high cost people that overuse the emergency room, overuse hospitalizations, and are not insured. And a great example of that is the Camden Coalition, which has been able to identify people that if you actually manage them outside the hospital with nurse practitioners or with EMTs visiting them, perhaps putting a nurse practitioner into a non-hospital setting, that you can actually get patients to do a much better job. And much of that is, it turns out, not to be healthcare. It's like housing or applying for disability insurance or getting more stable, moving from a motel to a permanent residence or cooking your own meals. So what turns out is that you need to have a different community resources helping the healthcare system take better care of these high-cost users. And the last thing that you need is IT infrastructure that gives the providers real-time information so that they can do a better job of keeping track of their patients in the system. I think there's several really good examples of systems that are moving toward clinical integration. One that I worked with was Flagler Hospital in St. Augustine, Florida. And we actually wrote a white paper called From Zero to SEN, SEN meaning Clinically Integrated Network, in 9 months. And basically the hospital and the physicians, both employed and independent physicians, realized that because of the pressures due to the clinical transformation of the healthcare delivery systems, that they were being asked by payers, health insurers, and employers to sharpen their pencils and do a better job of decreasing per capita cost and increasing quality. So in 9 months, we were able to get the hospital and the doctors to agree on a governance structure, to agree on some things that they needed to work on, such as decreasing length of stay in the hospital, decreasing the unnecessarily visits to the emergency room, and other quality improvement efforts, that they were able to set up a system that allowed them then to apply to the federal government to be a shared savings ACO, Accountable Care Organization, which is one of the structures that is usually used in a clinically integrated network. So the key critical success factors for anybody that wants to respond to the Affordable Care Act and the changes in payment, and the changes in payment are transitioning from fee-for-service to value-based payment systems. So those are things like bundled payment systems, those are things like accountable care organizations, those are things like pay for performance, and they're coming not just from the federal government, they're coming from private insurers as well. But the key characteristics are, really, it's about getting the doctors and the primary care doctors and the specialists on the same page. You know, most people believe that about 30% of all healthcare that we deliver is waste. And waste is really defined as, you know, the extra CT scan you really don't need, or the extra lab test you really don't need. And so if you can get a more streamlined way of taking care of patients, having them avoid using the emergency room when they don't really need to, avoiding unnecessarily hospitalizations. If you can streamline the relationship between primary care doctors and specialists, you can decrease that 30% of waste and use that for things like navigators, people that can help people get through the navigation of the system when they have cancer or when they have a chronic disease. So the characteristics of clinical integrated delivery systems that are earning shared savings are those that are able to decrease per capita cost and increase quality, and also increase patient satisfaction and increase the ability for doctors to feel more engaged in the care that they're providing. So we've talked about the triple aim, which is decreasing cost, increasing the experience of the physicians, and improving quality. But now some folks are talking about the quadruple aim, which is adding into that physician satisfaction as well. So I think that one way to summarize it is no outcome, no income, would be to say that a clinical integrated delivery system that's very successful is really hitting on all 4 cylinders of the quadruple aim.